Good morning. Thank you for the invitation, Dr. Herenga. I'm glad to be here. And like you said, we are hoping that we can develop a relationship going forward with pathology and fetal medicine. So I'm going to give you a very brief. I'm going to give you a very brief overview of the pathologist and the placenta. Of course, there's a caveat. We don't know fetal pathologists fetal pathologists in the country, but certainly we are generalists. We see quite a bit of placental pathology, surgical pathology, and also in the morgue, we do perform autopsies on a number of maternal deaths, and we look at the fetus at placenta. So just as a quick introduction, we recognize as pathologists that examination of the placenta is underutilized, which is unfortunate because the specimen is readily available and the cost is not that bad actually. It's a reasonable cost. There are a number of benefits. I think we'll talk about those just now. But I think one of the most is that you're able to manage your property, you are high risk for something. But also it's a very useful sort of technique for audit and as well as medical legal resolving medical legal issues. And of course, research is something that is critical. Pathology is something that's in most spheres of medicine. So from our perspective as pathologists, the placentas you should send, or rather you should not send all placentas because that is implications on the cost. It's potentially financially disastrous for most institutions. But there are guidelines developed by the College of American Pathologists, newer guidelines developed by the Royal College of Pathologists. So the newer guidelines are stricter, and perhaps I thought we should stick for now in our country because then that would limit the number of placentas we send in. The CAP guidelines result in a much higher proportion of placentas being sent for histopathological examination. But like I've already said, cost might be prohibitive. So what would make a pathology report, placental pathology report, useful? I think if it can explain clinical symptoms and the fetal outcome, and perhaps assist in prevention of same condition in subsequent pregnancies, then it is done. Essential features are clearly defined: diagnosis, evaluation of extent and severity, and even an estimation of future risk. What we're trying to prevent now is, or rather to minimize now, is having long lists of diagnoses, some of which can actually be misunderstood by non-specialists, fetal medicine colleagues, etc. And timeliness is important, and I'll touch on that as well just a little bit. And again, like Dr. Herenga said, really what we're looking at is an interdisciplinary sort of approach to fetal medicine. And I think placental pathology is one of those areas which really illustrates of it. We depend quite a lot on the clinical data that you put through, and when see specialist. And to address some of this, China workshop was convened in Amsterdam around September 2014, which was multidisciplinary, included fetal medicine specialists, pathologists, etc. And they agreed rather, house and they, criteria, immunology, and diagnostic criteria, etc. And the aim really was to standardize dietary and pathology. And I'll talk about those a little bit. I will not discuss the detailed anatomy and histology of the placenta because we wouldn't have enough time. But this is a pictorial cartoon just illustrating the basic um, anatomy of the placenta as we see it, or from our perspective as pathology. Right, so the Amsterdam Placenta Workshop Group really emphasized that there is need for recommendation. That is to say, what we see on the placenta when it comes to that is critical. In fact, might be the only diagnostic. Then, of course, microscopy is what we do best, and always try to detail that. But the most important section is the diagnostic section, actually, which provides unambiguous and clearly defined diagnosis. And then we often have a comment section where we correlate what we've seen and whatever information has been made available to us and try to discuss the pathophysiology. So I'll briefly run through these because they're pretty basic. But we often find that the clinical history is idiosyncratic, and it really depends on who's making the request. Some of it is complete and quite detailed, and some of it is just placenta, and the gestational age is not even stated. And that has implications, as you might imagine, on assessment in the proper clinical context. Right, the microscopic description, the placenta should be sent fresh. So we want to see it before it is being fixed, formal and fixative. And if need be, we can then obtain tissue for microbiology, cytogenetics, or some other molecular karyotyping processes. Of course, it's important not to include decidual maternal tissue because it will contaminate the specimen. And why I'm saying this is that the placenta should be assessed in both in the fresh and fixed states because some lesions are better seen fresh and some lesions can only be really characterized when the placenta is fully fixed in an adequate amount of formalin. So for the fixation, you need to immerse your placenta in approximately 10 times the volume of the placenta itself, 10 to 20 times the volume. There is a very wide range of parameters that we look at. Very wide range of parameters that we look at. We look at the membranes for color and translucency. We look at the insertion of the membranes. Are they abnormalities like circummargination or circumvallation? Obviously, try to measure the umbilical cord, but we don't often receive the whole umbilical cord. So that's not a very useful metric most times. We also want to look at the cord insertion, whether it's marginal or central, and for various other things like the coiling index, etc. We'll go on to then trim the membrane off and weigh the disc, look for check for completeness of the basal plate, and then section the placental disc parenchyma at maximum 1 centimeter intervals. And this will allow for a close or detailed inspection of the entire parenchyma of the placenta. And then, of course, we want to look at the maternal surface as well for evidence of retroplacental hemorrhage. We don't always see this, and we depend on the clinician to actually indicate that there was a retroplacental clot. But if we do get it, we measure it or weigh it. And then, of course, we need to sample it, and we need to take at least 4 blocks to adequately sample the cord, the membranes, and the parenchyma, minimum of 4 blocks. Then any other lesions are then sampled in additional blocks. So I think on average, you have 8 to 10 blocks that we submit for microscope examination for most placentas. But of course, if there's a significant pathology, the number goes up quite a bit. So it's pretty, from that long list I've just gone through for microscopy, it's easy to appreciate that you can miss out certain aspects of your gross or macroscopic inspection. So you actually need to have some sort of tool which allows you to be as complete or as thorough as possible. So we tend to use these pro forma or synoptic reports. So that lists all the items that you need to tick. That makes it much easier departments of the classroom. And the process or the time spent between receiving this one is sort of easy and all the detections. Okay, my apologies. The network is a bit unstable. As I was saying, I just trying to illustrate the process. So this tissue processing is really the step which takes the most time. We need about 14 to 16 hours. So essentially that's overnight. And then the subsequent steps, embedding, microtomy, etc., take another full day, I suppose. So really the minimum time is something like 72 hours, but it may be longer depending on load coming through to that particular lab. And in any case, placentas are not considered specimens by most labs, so they are sort of triaged into less urgent batch. Okay, so the next aspect of the report is really the microscopic, and it really depends on the institution. Some want to do a detailed prose. Some just indicate that with a little note that the sections have been examined and the diagnostic features are consistent with AB. And traditionally, some labs have really emphasized completeness, but the question was always, is there standardization and what is the clinical relevance of these very long reports that people wrote? So we've come to this, and it's partly due to the Amsterdam working group, where we tend to use synoptic reports, to help us to make diagnoses which are clinically relevant. So there are categories, diagnostic categories. I'm still on. There are diagnostic categories that now, gosh, what's X? 9 categories which encompass evidence of maternal vascular malperfusion, category 2, decidual arteriopathy, 3 is implantation site abnormalities, 4, of course, we're talking about uterine infection, which is pretty common. And then 5 and 6 talk about fetal villus maldevelopment and fetal malperfusion. And then 7, we don't see that much in the lab, but that's evidence of uteroplacental separation. Fibrinoid is fairly common. Thrombi, we don't see those that much as well. I think those placentas are not currently submitted. And then evidence of chronic inflammation, we do see it on occasion. So this synoptic sort of report or chart helps us really to make diagnosis, which are clinically relevant. I often get questions whether we have immunohistochemistry available. Yes, we do, but it's not particularly useful in the placenta, except in the case of identifying infectious organisms, e.g. viruses, etc. Right, so I've spoken about this already. And the comment section, like I said, is really useful to try and do what we call clinical pathologic correlation. But it works best when we've received adequate clinical data from the clinician. Okay, so the classification really is those 9 or 10 categories I've already referred to, so we'll skip that. And then I'm just going to show you a few pictures of some of the more common microscopic lesions that we see in the lab. Fetal vascular malperfusion, we do see it once in a while. I think the pathophysiology is really due to some cessation of blood into the placenta villus tree, so some vaso-occlusive lesions somewhere in the fetal vascular space leads to this involution of villi, and eventually they may actually become avascular. So of course the list includes prolapse of the cord, hypercoiling, knots, velamentous insertion, which predisposes it to trauma, etc. Okay, so that's one placenta which had a chorionic vessel thrombosis. So you can see the pale areas on the placenta. This is the gross examination. So there's quite a bit of a degree of infarction or and hypervelocity. And then on B, you can actually see the thrombus completely including that chorionic vessel just underneath the membrane. And you can see the avascular chorionic villi in panel C. So we do see that once in a while. Another one that we see, I think probably one of the more common diagnoses we make on the placentas that we currently receive is some sort of maternal vascular malperfusion. Of course, the pathophysiology is thought to do with implantation being abnormally shallow, etc. You do get vascular damage, which is often called decidual arteriopathy, and so the villi are more developed microscopically. They show accelerated maturation. They show the Tenney-Parker changes, which are just syncytial knots, and you get villus hyperplasia. So we can see two examples of this phenomenon here. Accelerated villus maturation. So if this was higher power, you'd be able to see the Chenery-Parker changes, but you can see how the villi are quite small. So that's the hypoplasia, and there's this increased deposition of the pink fibrin anyway, the increased perivillus fibrin deposition. On the right, you can see the so-called decidual arteriopathy. So the decidual vessels show what's called fibrinoid necrosis. So that pink, increased pink coloration of the vessel wall is fibrinoid necrosis. And this space contains foamy macrophages. And together, that's the so-called decidual arteriopathy. In the lab, like I said, we don't see placental hematomas that much, but we do see this quite a lot when we do maternal death autopsies. Abruption is fairly common. And when I was actively doing autopsies, I used to see these cases at least once a month, if not several times a month, from the various districts of the country. So this is just an example of chronic placental, retroplacental hemorrhage actually resulted in fetal death at 26 weeks. So you can see the organizing hematoma just behind the placenta there. And then B is an acute one, so the placental disc doesn't show many changes, but thankfully the clot was submitted together with the placenta, and it was then characterized. This is a microscopic. You can see the organizing clot behind. Abnormalities of umbilical cord insertion, not commonly seen in placentas we receive in the lab, but in the autopsy suite, we do see on occasion filamentous or membranous cord insertion, and always there's a bit of injury, like we see here. This one was ruptured, and this is a microscopic of that ruptured vessel, and this led to neonatal anemia of some sort. All right, I think this is quite common. We see maternal and fetal inflammatory responses for so-called ascending bacterial infections quite commonly. And we know that the fetal response occurs over the age of 20 weeks. And this is a microscopic, these are actually microabscesses within the parenchyma. And the microscopic correlates with, I'm sorry, the picture is a bit small, but this is a neutrophilic infiltrate within the membranes with some necrosis. So it's a necrotizing sort of process. Chronic velitis, I think, is fashionable among placental pathologists at the moment, whether we know the majority of cases are actually non-infectious, so-called velitis of unknown etiology, but this is a histopathologic diagnosis. The infectious one, I think commonly we used to see malaria, but not so much nowadays. And there are a variety of theories as to what's actually happening for you to develop the VUE. On microscopic, okay, so first of all, this is a chronic velitis due to an actual infection of the CMV. These are the typical viral inclusions that we see on the microscopic. And you may use immunohistochemistry, where this brown stain actually illustrates viral proteins which have been marked by our stain. The non-infectious one actually involves the infiltration of the intervillar space by macrophages with some lymphocytes. So it becomes very cellular within the intervillar space and don't see much blood. If you do immunohistochemistry like CD68, you can characterize the macrophages very well. All right, I think this is one of the last ones. We've seen a few cases in placentas we've received. Massive fibrin deposition and maternal flow infarction. Really what's happening, there's increased deposition of fibrin within the parenchymal placental disc, And there are a variety of etiologies which have been suggested, which range from autoimmune, latent infection, and to major basic issues. And I think it's an important diagnosis to make of the associated poor outcomes and the risk of recurrence. I think some authors say 20%. And this is what we see. Essentially, the placental disc is very pale or whitish. It's a fibrinoid which has been deposited within the parenchyma instead of the reddish, brownish reddish, spongy appearance. And you can see the same pink material deposited throughout with associated ischemia of the villi. This is why it's so critical, because it causes very significant ischemic changes. All right, I think, like I said, the last one, the very last one that we see is I think this is a typo, supposed to be chorangioma, most common tumor of the placenta that I've seen, and I think literature talks about as well, the chorangioma. Usually of no clinical significance unless it involves more than 30% of the placental disc. I'll show you a picture just now. But of interest, we've seen quite a number of somatic tumors in the parenchyma of the placenta. We don't have statistics for our local placentas, but elsewhere, melanoma is the commonest, followed by breast carcinoma, and then hematologic malignancies. The chorangioma, pretty big lesion. I think it effect on the fetal outcome. And of course, it's just a vascular lesion, well circumscribed vascular tumors of capillary caliber size. All right, so that's a very brief overview. Just try to highlight what we're doing to try and standardize pathology, make it easier to interact with fetal medicine specialists, and of course also make life of non-specialist pathologists easier in assessing the placenta.